Now that we've covered the basics of narrow complex tachycardia and paroxysmal SVTs, namely AVRT and AVNRT, it's time to give the rest of the SVTs their due. SVT, or supraventricular tachycardia, is merely a term used to describe any tachycardia arising from above the ventricles, or in the case of reentrant circuit tachycardias, the impulse travels above the ventricles as part of its cycle. SVT then includes anything from AFib and flutter down to junctional tachycardia, which arises from the AV node. Today at the Old Folks Home, we're going to take an in depth look at AFib, aflutter, and both focal and multifocal atrial tachycardias. And if we have enough time, some pool exercises, bingo, and maybe catch an episode of Howdy Doody before nap time. Since these arrhythmias typically present as tachyarrhythmias, we've put an elevated heart clock on the wall. If the QRS complex is less than 120 milliseconds, less than three little boxes, in other words, it's classified as narrow complex. So, on the retirement facility logo, we've drawn in a narrow QRS pine tree. Remember that the duration of the QRS complex is the amount of time it takes for the ventricle to depolarize. If our electrical current is flowing from the atrium through the AV node and down the normal conduction system of the heart, this is the fastest way for the heart to depolarize and should take less than 120 milliseconds, creating a narrow QRS complex. Expect the SVTs we encounter today, AFib, aflutter, and atrial tachycardia, all of which originate in the atria, to filter through that AV node and produce narrow QRS complexes. Though keep in mind that we will see SVTs, such as AFib and aflutter, create wide complex tachycardias as well. But this is only if they hit an aberrant conduction pathway on their way to the ventricles. Think of a bundle branch block delaying ventricular depolarization, or an accessory pathway causing ventricular pre-excitation. In either case, slower depolarization causes wide complexes. Head on over to the police station for all the details. Meanwhile, back at the Old Folks Home, we're going to start with atrial fibrillation. AFib is a condition in which the coordinated, regular electrical signals of the SA node is lost, and the atria begin to fibrillate or send continuous, chaotic electrical signals from all over. AFib is most commonly caused by ectopic foci located in the myocardial tissue surrounding the pulmonary veins. Hence the four venous looking tubes entering the TV, just like the four pulmonary veins that dump into the left atrium. The atrium can generate over 350 electrical signals per minute, but only some of these signals are transmitted down the AV node, leading to an irregularly irregular ventricular rhythm with a ventricular rate usually somewhere in the 100 to 200 BPM range, depending on the refractory period of the AV node. On the ECG, expect to see an irregularly irregular rhythm with different RR intervals in no obvious pattern. And if you're expecting to see any P waves, you're out of luck. A P wave, remember, represents the coordinated depolarization of the atria. And in the setting of fibrillation, definitely uncoordinated. Instead of P waves, expect to see a wavy, erratic baseline between the transmitted QRS complexes. The low amplitude oscillating waves you'll find there are dubbed fibrillatory waves or F waves. That's lowercase f. AFib can be categorized as either paroxysmal, persistent, or permanent. Paroxysmal AFib is intermittent, or resolves within 7 days of onset, either spontaneously or with antiarrhythmic or rate control therapy. Persistent AFib is any episode lasting longer than 7 days. AFib often progresses from paroxysmal to persistent. Persistent AFib becomes permanent AFib when the patient and physician decide to no longer pursue any rhythm control strategy. Next, atrial flutter. Depicted here by this little wiener dog terrorizing one of the residents as his ears flutter behind him. Typical atrial flutter is caused by a reentrant circuit around the tricuspid annulus, traveling through what's called the cavo-tricuspid isthmus, which sits between the inferior vena cava and tricuspid valve. This circuit fires at very close to 300 beats per minute. On the ECG, you won't find P waves. Instead, you'll see atrial flutter contractions or flutter waves in between each QRS. They're generally described as forming a sawtooth pattern and are dubbed F waves. This time a capital F. The AV node blocks some of these impulses and others get filtered through, forming narrow QRS complexes as the ventricles get activated. Which is why this fluttering wiener dog is performing lots of little hops, but every once in a while a big jump as she depolarizes the ventricle, if you will. Usually only one out of every two signals are transmitted through the AV node down to the ventricle, resulting in a QRS complex. This is called atrial flutter with a 2 to 1 block and results in a ventricular rate of about 150 beats per minute. Notice that we've incorporated both 300 and 150 into the walker she's using to block the dog's jumps. Other ratios, such as a 3 to 1 or 4 to 1 conduction, can occur as well, with even numbers being more common. If there's no variability to the AV block, a regular tachycardia develops. But if the degree of that block changes from second to second, which is common as well, it can result in different RR intervals and an irregular rhythm. So, in front of this next lady, with the varying sizes of notes on her dress, think of varying degrees of nodal block. You can see that the dog is jumping more erratically and irregularly as the impulses get through. Alright, let's fill out that soap note, shall we? While AFib and AFlutter may have differing electrophysiology, they have very similar risk factors, presentations, and treatment goals, and will therefore be discussed together. The presentation of AFib and AFlutter can vary greatly depending on whether the patient is presenting with a new onset episode or the 10th recurrence in a patient with paroxysmal AFib. Sometimes AFib and AFlutter can even be completely asymptomatic and discovered during medical evaluation for other reasons. Though I wouldn't call Hilda over here asymptomatic. Staring at the wall and laughing is just kinda her thing. Anyways, the most common chief complaint that you'll encounter is palpitations. An episode of the irregular zone will do that to you. Without coordinated atrial contraction, patients lose their atrial kick, which decreases left ventricular filling. This is especially detrimental in patients with underlying diastolic dysfunction who rely on that atrial kick for that last little boost in preload at the end of diastole. What results is decreased cardiac output. On top of that, tachycardia as well as an abrupt irregular rhythm can further decrease cardiac output. And finally, or thirdly, prolonged tachycardia in the setting of chronic uncontrolled AFib can actually lead to tachycardia mediated cardiomyopathy, which is usually reversible once controlled. All in all, what you end up with is heart failure or worsening heart failure in patients who already have underlying disease. Keep in mind that heart failure itself is a risk factor for developing AFib and AFlutter. So, which came first, the fib or the failure? Definitely one of those shower thoughts. Patients may report dizziness, lightheadedness, or altered mental status due to hypotension. Pulmonary congestion, exertional dyspnea, and fatigue can lead to exercise intolerance. More severe presentations may involve chest pain due to tachycardia mediated demand ischemia. Again, just want to emphasize that ischemia itself can cause the arrhythmia. So you gotta figure out what the real chief complaint is, my friend. That could be a heart attack. Once again, the HPI is important to identify the timing of onset, especially when it comes to treatment, associated symptoms, and severity. But due to the vast amount of reversible triggers, a thorough social history, surgical history, and past medical history are going to be especially important. AFib is the most common type of arrhythmia, with around 3 to 6 million people in the US affected. AFlutter is much less common, but has a very similar profile of risk factors. Risk factors for both AFib and AFlutter include age, with increasing incidence in older individuals and a higher prevalence in men versus women. Factors that cause strain on the atria predispose to the development of AFib and AFlutter. In particular, atrial enlargement, increased atrial pressure, or inflammation of the atria. In the developed world, hypertensive heart disease and coronary heart disease are the big ones. Hypertension, over time, causes concentric remodeling and diastolic dysfunction of the ventricles, which contributes to increased atrial pressure and size. Coronary heart disease really only becomes a risk factor when there's a history of MI or heart failure. Again, congestion leads to increased atrial pressure and size. In the back there, hypertension is symbolized by the pressure in that old heater, and MI plus heart failure are symbolized by the broken heartstrings and floppy heart balloon, respectively. Man, this party sure died. Other risk factors to consider include valvular heart disease, hence the faulty valve there. We're talking stenosis or regurgitation of any valve, really, sending back pressure to those atria. In less developed areas, valvular rheumatic heart disease is of particular concern. Rheumatic rhubarb pie, anyone? Nah? No takers? Recent cardiac surgery is another risk factor for development of AFib and AFlutter, especially CABG and valve replacement surgery. Pulmonary disease can also put strain on the right atrium, thus contributing to the development of AFib and AFlutter. This includes processes such as acute pulmonary embolism or even obstructive sleep apnea. That's how core pulmonale do. Other chronic disease states, such as obesity and diabetes, are also associated, though the underlying pathophysiology isn't entirely understood and probably multifactorial. Excessive alcohol intake is another risk factor for the development of AFib and aflutter. Acute binge drinking, for example, can cause what's called holiday heart syndrome, in which AFib develops in individuals without any underlying cardiomyopathy. Chronic excessive alcohol intake, on the other hand, may lead to development of alcoholic cardiomyopathy, a dilated cardiomyopathy associated with various arrhythmias. Look out for a history of thromboembolic disease, a major complication of AFib or aflutter, whether episodic or chronic. Loss of coordinated atrial contraction leads to stagnation of blood in the atria and, potentially, the formation of a clot, usually in the left atrium or atrial appendage. When this happens, small pieces of this clot can embolize to other areas of the arterial system, resulting in acute ischemic strokes, acute limb ischemia, or acute visceral ischemia, such as acute mesenteric ischemia. Just think of these ischemic poops here embolizing from above and causing all kinds of bodily harm to unsuspecting passersby. For patients with a known history of AFib or aflutter, ask about home meds. Look into what kind of treatment strategies were used in the past and see if they've been compliant. They might be on anticoagulation to prevent thromboembolism, usually oral drugs such as warfarin or one of the novel oral anticoagulants. Also, you might spy some antiarrhythmic drugs on that med list. These are for rate or rhythm control, symbolized in this unit by a rate controlling metronome and a rhythm inducing record. Why were these stuffed into this resident's home med bag, you ask? Don't worry, we'll get all into the details regarding anticoagulation and rate and rhythm control in these patients over in the next sketch. Vitals and physical exam time. We've already kind of covered most of it, actually. We're looking for tachycardia, of course, and with AFib, an irregularly irregular rhythm. Aflutter will be either regular or irregular depending on the degree of AV block. And as we discussed earlier, AFib and flutter and heart failure go hand in hand. Not only is heart failure a risk factor for the development of AFib and flutter themselves cause or exacerbate heart failure, especially in patients with underlying diastolic dysfunction. It's like a whole chicken and the egg scenario going on over here. Anyways, check for the usual signs and symptoms of heart failure, such as peripheral edema, JVD, pulmonary edema, and a cardiac gallop. Additionally, assess for signs of hemodynamic instability, including hypotension and altered mental status. These patients are going to require immediate treatment. And, of course, inspect that ECG. Now, we already went over the key features of AFib and flutter on the ECG, but it's important to check if other supraventricular tachycardias are present as well. Check for signs of ischemia and look for related structural abnormalities, such as bundle branch block or chamber enlargement. As for labs, the workup of AFib and flutter is generally dictated by the symptoms, and there's no one size fits all approach. A young patient without any chest pain or ischemic changes may not need cardiac enzymes ordered. But in an older patient with CAD, chest discomfort, ischemic changes on ECG, or many cardiac risk factors, serial troponin may be indicated, represented here by the early bird special, frozen troponin T-bone steak dinner. Again, we've got cause and effect issues here. Remember that an acute heart attack can precipitate an episode of AFib or flutter, or on the flip side, uncontrolled AFib or aflutter can cause demand ischemia in an older patient. While a metabolic panel and magnesium is not absolutely necessary in all patients, it can be helpful to assess in some patients, as sodium, potassium, calcium, and magnesium all participate in cardiac depolarization, and abnormalities could have predisposed to the development of the arrhythmia. Also, look for signs of renal dysfunction, as those altered hemodynamics may be precipitating some insidious kidney injury. A TSH should be considered in patients with their first episode of AFib and aflutter, as well as patients with other findings concerning for hyperthyroidism. To represent TSH, as always, we've drawn in a thyroid bow tie getting tightened, stimulated, if you will. That's what TSH do. Will Hilda finally notice Hank, her secret admirer, now that he's made himself presentable? Or will she continue to talk to inanimate objects? A tale of forbidden love. Tune in next week to find out. Outside at the cardio pool, I want to briefly mention transthoracic echocardiogram, an important part of the routine workup of a patient with AFib or aflutter. Notice that around the group exercise instructor yelling through the echo horn, we've drawn cracks in the pavement. A little reminder to look for evidence of underlying heart disease, such as prior MI, valvular disease, pericardial disease, left ventricular hypertrophy, or heart failure, that may have predisposed the patient to AFib. Left ventricular function also dictates the treatment strategy. A patient with systolic dysfunction will probably need a beta blocker to improve survival, along with digoxin for symptom control. We'll bring this up again in our treatment video. And you see that especially dilated lady in the top left chamber of the pool? The anatomical left, that is. Left atrial dilation is common in AFib and AFlutter. Left atrial enlargement, due to an underlying condition like heart failure, strongly predisposes to development of arrhythmia. Also, the arrhythmia itself can cause atrial dilation. And this is often reversible after restoration to sinus rhythm. Whoa, doctors are super people. What if the AFib AFlutter has caused a clot in the left atrium or left atrial appendage? It sure looks like there's a lot of stasis going on in there as we speak. Well, there's a good chance you won't see the clot on transthoracic echo, particularly if it's in the left atrial appendage. That's why we've made these sticks clogging up the right atrium of the pool obscured. You just can't see what's lurking in there. A transesophageal echo is a far more sensitive test for detection of a clot, but it's more invasive and not routinely used. Transesophageal echo is most helpful for dictating management, specifically whether patients with new onset AFib can be cardioverted early or not. We'll get into that in the next sketch. Oop, I think I hear the last call for old people yoga time. I think we still have time for a quick sample assessment, don't you? Alfred is a 70-year-old male patient with a history of hypertension, CHF, and COPD who presents with 2 days of palpitations, lightheadedness, fatigue, and dyspnea on exertion. He denies any chest pain, leg swelling, orthopnea, or change in medications. His heart rate is 160 BPM with an irregular rhythm and BP of 124 over 84. The remainder of the cardiorespiratory exam is unremarkable. ECG shows an irregular rhythm at a rate between 140 and 160 BPM with no discernible P waves and narrow QRS complexes. No signs of ischemia are present. Troponins, electrolytes, and TSH have been ordered. Given the patient's risk factors, symptoms, and ECG findings, I'm concerned for new onset atrial fibrillation. Alright, we're saving the management of AFib and AFlutter for our next sketch. So let's wrap up here with focal and multifocal atrial tachycardia. Because these rhythms are starting in the atria and being fed through the AV node, in the absence of any kind of aberrant conduction, of course, these conditions belong to the category of narrow complex tachycardia. So the narrow pine and elevated heart watch symbols apply here as well. Note that multifocal atrial tachycardia, or MAT, is dubbed merely a multifocal atrial rhythm or wandering pacemaker when the patient has all the ECG features of MAT, just without the tachycardia. Let's take a look at the ECG features of MAT over on the yoga mats. The multifocal part means that at least 3 areas of the atrium have pacemaker activity and are generating electrical signals transmitted to the ventricles. Multiform is probably the better term to use, however, since the underlying mechanism may, in fact, involve a single focus of electrical activity with multiple conduction pathways. Nonetheless, the rhythm of MAT exhibits P waves representing atrial depolarization, and these P waves have at least 3 distinct morphologies. Some will be taller, some will be wider, and some could even be inverted on the ECG. And in this scene, these 3 yogis are all bending over in a P shape with obvious differences in morphology. The rhythm will be irregularly irregular. So we've installed another TV in the corner playing the same episode of the irregularly irregular zone. So, logically, if multifocal atrial tachycardia has 3 or more P wave morphologies, a focal atrial tachycardia, which involves abnormal atrial pacemaker activity outside of the SA node from a single focus, should only have 1 kind of P wave morphology. If you were already thinking that, you'd be right. That's why the skeptical resident here is focusing on that single P-shaped yoga logo on the front of the brochure. This time, the rhythm is regular. Now, if this focus of electrical activity is close to the SA node, the P waves may actually look pretty normal, representing a relatively normal and coordinated atrial depolarization. But, more commonly, the focus is far enough from the SA node that there's an appreciable difference in P wave morphology compared to the patient's baseline sinus rhythm strip. So get a hold of an old ECG to compare. In general, it's important to assess for any conditions that can precipitate atrial arrhythmia in these patients, such as heart failure, cardiomyopathy, MI, infection, and electrolyte disturbances. Fortunately, non sustained focal ATAC is typically benign in adults, though sustained ATAC can lead to a tachycardia mediated cardiomyopathy. Treatment of patients with recurrent symptomatic disease include beta blockers or calcium channel blockers, as well as catheter ablation. Not a very interesting story, huh? Well, multifocal atrial tachycardia is a bit more interesting. In a majority of patients, MAT is associated with significant pulmonary disease and is common in the setting of acute pulmonary failure. COPD is the most commonly associated condition, represented as usual by a blue bloated dude. Though keep in mind that other pulmonary pathologies, such as pneumonia or PE, can be associated as well. MAT can also occur in the setting of heart disease, especially if heart failure is involved. Other risk factors include metabolic derangements and certain drugs, so make sure to get a full medication history and check those lights. MAT is usually found somewhat incidentally on bedside cardiac monitoring, ECG, or physical exam. In contrast to AFib and AFlutter and our other tachydysrhythmias, patients generally do not present with symptoms due to the arrhythmia. Instead, the clinical picture is dominated by the underlying condition, such as COPD exacerbation, causing the MAT in the first place. Let's see what this looks like in a sample assessment, shall we? Matt is a 72-year-old male smoker with a past medical history of severe COPD coming in with 3 days of cough, wheezing, and shortness of breath. Physical exam is notable for expiratory wheezing, tachypnea, and an irregular tachycardia. Electrolytes are within normal range. ECG shows an irregular narrow complex tachycardia at a rate of 130 bpm with multiple distinct P wave morphologies. No signs of ischemia are present. I suspect an acute COPD exacerbation with concomitant multifocal atrial tachycardia. MAT rarely causes any hemodynamic compromise, so treatment is generally aimed at reversing the underlying cause, such as improving oxygenation and decreasing the work of breathing. It's usually self limited and resolves with correction of the underlying disease. If significant hypomagnesemia or hypokalemia is found, electrolytes should be adequately replaced in conjunction with treating any pulmonary disease process. In the rare case that medical management of the underlying cause does not resolve the arrhythmia, and that the symptoms are felt to be due to the tachycardia itself, beta blockers or calcium channel blockers can be used to slow the ventricular rate. So we've drawn in our recurring symbols on the sign there: a calcium ice cream dispenser and a muted beta bugle. Unlike AFib and AFlutter, there's no role for rhythm control agents or electrical cardioversion in the setting of MAT. Alright, great job everyone! Now just a final Uttanasana pose.